basics of lumbar and thoracic epidural anesthesia and tips for consistency. Epidural anesthesia, as we all know, was first described by Corning in 1901, and since then it has come a long way to become a very prominent feature in our day-to-day practice. So today we are going to consider the lumbar and the thoracic epidural in this talk. And to begin with, we are going to refresh our knowledge of anatomy of the epidural space, then consider the indications, contraindications, and techniques of the lumbar and thoracic epidural, followed by the nuances of pearls and pitfalls of the procedure. And to conclude, we are going to go through the literature review. So this will be my agenda for the next 15 to 20 minutes. So to begin with lumbar epidural, coming to the anatomy, the topography of the epidural space. So in this cross section, what you can see through cadaveric cross section through a lumbar vertebra, and you can see the lumbar vertebral body over here with the spinal cord, which is in the center. Now, in this lumbar region, this is not actually the spinal cord, but it is the chorda equina. So you can see very small nerves over here, the nerve roots over here, a lumbar nerve root, which has come out through the intervertebral foramen. And you can see the musculature around the back, the erector spinae muscles on each side of the spinous process, and the psoas major in front of the transverse process. And within the psoas muscle, you can also see the elements of the lumbar plexus. Now, what is the area of interest for us is the epidural space, which is a triangular space over here, and which is lined by posteriorly by the ligamentum flavum. This colored area is the ligamentum flavum, which is of particular interest to us. Why? Because it gives us the tactile feedback of the loss of resistance when we are doing a epidural. So coming to the boundaries, anteriorly, the epidural space is bounded by the posterior longitudinal ligament, the vertebral body and the intervertebral discs, laterally by the pedicles and the intervertebral foramen, and posteriorly, which is particularly our area of interest, by the ligamentum flavum, the capsule of the facet joints, and the laminae over here. So this epidural space is a triangular space, and preceding to that, from the skin you encounter the supraspinous ligament, the interspinous ligament, the infraspinous ligament, to finally reach the ligamentum flavum, and this gives us the loss of resistance to enter the epidural space. So the common indications for lumbar epidural, all the pelvic and the lower abdominal surgeries can be done solely under epidural anesthesia or can be used for analgesic purposes for all the lower limb surgeries, for labor analgesia, and even epidural finds a place in the management of chronic radicular pain in the form of epidural steroid injection. There are certain contraindications. The absolute ones include patient refusal, presence of coagulopathy, raised intracranial pressure, and allergy to local anesthetics. Other contraindications are quite relative, like fixed cardiac output state or spinal deformity, neurological disorders, sepsis, and deranged coagulation. So now we'll just see a short video to show the technique of the epidural anesthesia in the lumbar region. So this was a case of intertrochanteric fracture of the femur to be done under spinal epidural anesthesia. So the level which was selected was L3-4. Local infiltration done, and epidural needle with Tuhi epidural needle was used with loss of resistance for air. The epidural space was obtained at 3 centimeters. So the distance calculated, test dose given, and catheter threaded through the Tuhi needle and fixed at around 7 to 8 centimeters. So this is a lumbar epidural. This was given for analgesic purposes in a very frail old woman in whom it was combined with a spinal anesthesia. Now the complications. There are minor complications which can be easily tackled, and they are self-limiting. Accidental dural puncture can occur, leading post-dural puncture headache. There may be transient neurological symptoms which do revert on their own after a certain period. But the major complications which are of concern to us is occurrence of epidural hematoma, which becomes an emergency and requires immediate decompression. There may be neurological injury, but the incidence is very low. Similarly, the incidence of epidural abscess is also very low, and proper aseptic precautions can definitely prevent this. Total spinal anesthesia may occur if accidental dural puncture occurs. A large amount of local anesthetic is injected into the intrathecal space, and this might lead to spinal anesthesia. So complete vigilance is very necessary. Similarly, due to intravascular injection of large volume of local anesthetic, it may result in last or local anesthetic systemic toxicity and might result in a cardiac arrest. So, like ultrasound has gained a lot of popularity in the recent years for peripheral nerve blockade. Similarly, it has also found its place for in the central neuraxial procedures. So for detection of epidural space, again, ultrasound guidance has been promoted a lot. Particular views which can be obtained for doing an ultrasound of the lumbar epidural. So these are the parasagittal transverse process, the parasagittal articular process view, and most important for us is the parasagittal oblique view or the interlaminar view. Similarly, in the short axis, the transverse spinous process and transverse interlaminar views are also important for us. If you go for a parasagittal oblique interlaminar view, what you are going to see are the laminae, which are described as the horse head appearance, and the interlaminar space in between. You see the posterior dura, the anterior complex, the posterior complex, and the intrathecal space. So this interlaminar space is the place where you can place your epidural needle. So we can do a surface marking to exactly identify the point of needle insertion for the epidural anesthesia. And with in the lumbar region, particularly, we use a curvilinear probe, and we try to place the probe in a parasagittal oblique orientation so as to get this view of the laminae and the interlaminar space. Then identify the posterior and the anterior complexes, and this could be your point of needle insertion. So how we mark the point of needle insertion is the midpoint of the long edge of the probe. So after this, the probe is rotated to obtain a transverse view. And in the transverse view, what is visible is the spinous process and the articular processes and the facet joints and the lamina and the posterior and the anterior complexes. So when we place the probe in a transverse orientation, again, the midpoint of the long edge and the short edge is marked, and the point of intersection of these two lines can be taken as the point of needle insertion. So in this meta-analysis by Chin and Karmakar, they found that the use of ultrasound for adult thoracic and lumbar neuraxial blockade has provided with a lot of advantages. The interspinous space identification was accurate, and it was accurate in more than 76% of the subjects. Similarly, the depth of epidural space could be calculated, and the difference between the actual and the measured distance from ultrasound was less than 5 millimeters. So that was the precision with which you could identify the depth of the epidural space, epidural to spinal space. So all this led to an improvement in the clinical efficacy. So there were almost 79% reduction in the failure rate because of the precision, and there was improvement in the technical performance. So the number of needle passes decreased, and this was their own study where they assessed patients with a BMI of more than 35, and they found that the number of needle passes decreased by more than 50%. So that's how useful ultrasound is in doing a central neuraxial block. Next, coming to the thoracic epidural. Again, the topography of the thoracic epidural space, the basic difference over here is the presence of spinal cord as against the nerve roots of the chorda equina in the lumbar area. Again, here it is similarly bounded anteriorly by the posterior longitudinal ligament, the vertebral body and the intervertebral disc, and laterally by the pedicles and the intervertebral foramen, and posteriorly by the ligamentum flavum and the capsule of the facet joints and the laminae. So here what is important for us to remember again is the ligamentum flavum, identify that, and this is going to give us the loss of resistance tactile feedback. Indications, again, it can be used for a variety of thoracic and upper abdominal and lower abdominal surgery for analgesic purposes. So this was a case of open cholecystectomy. The level which was selected was around T8, T9 or T10, T9, T10. And in this case, loss of resistance to saline was utilized. The epidural space was obtained at around 4.5 centimeters, and the catheter was threaded through the needle and fixed at around 8 centimeters. It provided a good analgesia for the procedure intraoperative as well as postoperative. So that's how the catheter was threaded. Gradually, the needle removed and catheter fixed. So complications are similar to that in the lumbar epidural. The overall incidence is less than 3%. And the minor complications include unsuccessful catheter placement, possibility of a dural puncture, which was 0.7%. It was more in the lower thoracic region as compared to the upper. And postoperative radicular pain was again had a very low incidence. Major complications of a thoracic epidural, they are rare but very devastating, and includes neurological injury, which could be a spinal cord injury or injury to the nerve roots. Occurrence of epidural hematomas, again a very serious complication, though it's very rare, less than 1 in 1.5 lakhs. And occurrence of epidural abscess, which can easily be actually prevented. So as in lumbar epidural, ultrasound can also be used for detection of epidural space in the thoracic region. Now here we are preferably using a linear probe, and if you see this here, these are the probe positions for the epidural in thoracic region. And here the difference between the lumbar and the thoracic is that the laminae which were seen as having a horse head appearance in the lumbar region, now here they appear as a flattened areas. So these are the flattened laminae and the interlaminar space in between them. So the probe position is again similar for parasagittal thoracic spine scanning in the parasagittal plane, and for transverse in the short axis, again it is similar to that of lumbar area. Again, the surface marking to be done similarly, but here we are using since the face is quite superficial, spine is quite superficial, we can use a linear probe to identify the processes, the transverse process and the spinous process. So we can use a linear probe, and similar to the lumbar area, the markings are done at the midpoint of long edge of the probe, and the needle can be inserted through the point of intersection of those lines. So what does the literature say now? There's this meta-analysis which says that statistically but not clinically superior analgesia is found in nearly 87% of patients. So there was improved pain control with thoracic epidural anesthesia. The sympathetic block, which is caused by thoracic epidural, particularly in the upper thoracic region, the T1 to T4, results increase in the coronary perfusion, and this may provide cardiovascular stability and improved outcome in myocardial revascularization surgery. It also causes a reduction in the ischemic pain, and thus overall there will be cardiovascular stability will be achieved. So similarly, in the mid-thoracic region, block of the splanchnic sympathetic nerves will lead to a better perfusion of the intestines, and thus it has shown to decrease the incidence of postoperative ileus and early restoration of the bowel function in the postoperative period. So because of its superior analgesia which it provides, it also reduces the pulmonary complications. There's decreased incidence of atelectasis and pulmonary infections. And similarly, in the case of multiple rib fractures, because of the superior analgesia that it provides, there's reduced mortality. Thus, it has a lot of clinical applications and has always been gold standard for analgesia in all the thoracic and lumbar procedures. Now, identification of epidural space the loss of resistance was first described by Dogliotti. And when we were training in our residency, we used to use glass syringes, but with a lot of advancements now, there are a lot of plastic syringes which are available, produced by BD and Potex and all. And these are specialized syringes which facilitate a loss of resistance, tactile feedback when we are doing an epidural. Fine Face, Oga and Mato, they described this epidural balloon, which as the needle advances and pierces the ligamentum flavum to enter the epidural space, the balloon will get deflated and indicates the precise positioning of the needle tip within the epidural space. So this is one modality. And there is this Episure syringe, which has a reinforced piston with a spring, and this provides a very consistent pressure as the needle advances into the epidural space. So these are the various gadgets which can be used for identification of epidural space. And then there's this advanced modality where stimulating catheter can be used, and this stimulating catheter can be lateralized to one side to provide a unilateral analgesia. This has been mentioned, but practicality of this into day-to-day practice is yet to be ascertained. Then why do we need basically the imaging techniques for epidural space? Well, there are a lot of modalities that we use. We use X-rays, we may use CT scan, we may use MRI or ultrasound to identify the epidural space. So all these modalities basically we are using in order to increase our precision to reach the epidural space without causing much discomfort to the patient. So why is it necessary? Because of the differences in the anatomy of the spine in the thoracic and the lumbar areas. So as you can see here in the upper thoracic region, the spinous processes are practically they are overlapping each other, and there's hardly any space for the needle to go through these. So if you're using a midline approach, it may be practically impossible to reach the epidural space through the midline. The number of attempts will increase, cause a lot of discomfort, maybe bleeding. So in order to avoid all this, we are using all these modalities for doing an epidural. And as mentioned earlier, with ultrasound, the spinous process is correctly identified in more than 76% of the patients. So another modality which has been used practically is the fluoroscopy guided epidural technique. This finds its place more in the chronic pain management for giving a transforaminal block. And here in this, they use the pedicle as the major landmark for reaching the epidural space. So the advantage is that it allows for precise needle angulation and localization of catheter at the target vertebral level. But it cannot be used in every case, as this involves a lot of radiation exposure, and it is not necessary. Most of the, in 90% of the patients, we, without using any modality also, we can reach the epidural space. So it's not that feasible. Similarly, CT scan guided epidural. This has to be reserved for very special cases where it is really impossible to go for any peripheral nerve blocks, or there is very gross abnormality of the spine. So even the authors have recommended to use this only by a skilled anesthesiologist and combine it with, say, a stimulating catheter to increase the precision. So now there are certain special situations where these patients might present to you with spinal instrumentations. They may be on anticoagulants, and these really pose a very clinical dilemma to us regional anesthesiologists. If we have a patient like this who has undergone a scoliosis surgery and has got so much instrumentation in the back, so preoperative radiograph will be helpful for us to identify the epidural space which we can select for doing the epidural anesthesia. So these modalities are very important. So you can select the space and then you can decide where you are going to put your epidural catheter. Similarly, in such cases, but however, there are chances of misplaced catheter in spite of having all these preparing like this with a preoperative radiograph and everything. There could be misplacement of the catheter. It might land up in the paravertebral space or elsewhere. So you need to be very careful when you're putting a epidural catheter. So in these cases, the stimulating catheters might help. So you can precisely identify at what level your catheter is, where your catheter is. This is one topic which is very important for all of us regional anesthesiologists, that is neuraxial blocks on patients who are anticoagulated. And European Society of Regional Anesthesia has laid down guidelines which you can access through this journal of 2022. And they have put up certain guidelines for all the anticoagulants and the time from the stoppage of the drug to the intervention, and then starting of the drug after the intervention. So particularly for important for ones for us are like aspirin, where they do not really ask us to stop the drug. It can be continued through the procedure. And then there is ticagrelor and clopidogrel, which needs to be stopped nearly 5 to 7 days before doing an epidural. Similarly, for these other drugs, the low molecular weight heparins, where either 12 hours or 24 hours stoppage is indicated. Now, because of all the anatomical variations which are there in the spine, we need to refine our skills in order to get to the epidural space right in the first attempt. So there is this article by Halizinski in which they have assessed the anatomy of the lumbar and the thoracic spines, and they have precisely mentioned the needle direction, the angle at which the needle should be inserted when you're going in a midline and in a paraspinous approach. So in a lumbar epidural, where the spines are nearly horizontal, the needle insertion can be done through a midline approach with a slight 10 degrees angle from the horizontal. So this is the horizontal, and from there a slight 10 degrees angle in the kephalate direction will facilitate entry into the epidural space in between the two spinous processes. Whereas when you are going for a paraspinous approach, the angle again from the midline is around 10 degrees, and from the horizontal around 45 degrees angulation of the needle will lead to a proper insertion of the epidural needle into the epidural space through the interspinous space. So this is the 45 degrees angle from the skin where the needle is inserted in a kiphalat direction and with a slight 10 degrees angle from the midline. As against this, if you see the thoracic spine, as I mentioned earlier, the spines are in the upper thoracic region. They are totally overlapping each other, and it is virtually impossible to reach into the epidural space through the midline. So, and hence a paraspinous approach is advocated in the thoracic region. Now here also they have precisely indicated the angle of the needle around 25 degrees from the midpoint of the spinous process. So if you see, this is the midpoint of the spinous process, and from there around an angle of 25 degrees is indicated for a epidural needle insertion to go through the interlaminar space. This is done to achieve a precise insertion of the needle into the epidural space. Another important thing which we need to remember, in particularly in the thoracic region, is the presence of gap in the ligamentum flavum. Now these gaps are having their origin in the embryonic stage, where there is in the midline there is a gap in the ligamentum flavum. This is a ligamentum flavum and there's a gap in between. And why this is important is because ligamentum flavum is the thing that gives us tactile feedback of loss of resistance. So here you may inadvertently just go ahead and puncture the dura. There is an increased incidence of accidental dural puncture when you are going through the midline, and hence a paramedian approach or a paraspinous approach is advocated, particularly in the thoracic area, so that you don't go through this gap in the ligamentum flavum. One more controversy which always has been there, whether to use air or saline for the loss of resistance technique for identification of the epidural space. So this Cochrane Library Database Systematic Review, they concluded that there was low quality evidence which shows that the results do not differ between air and saline in using loss of resistance technique for identification of epidural space and in reducing complications. So there are other articles as well which also show similar results. So whether you use air or saline, it does not really matter. You can use any of them. So to conclude, thoracic and lumbar epidural can be used for analgesia and anesthesia for procedures on the abdomen, thorax, lower limb, pelvis, and also for chronic pain. Now for thoracic epidural, the angulation of the needle is very important for a successful passage through the interlaminar space. Always remember the gaps in the ligamentum flavum, particularly in the thoracic region. These gaps are mostly found in the from T10 to T12. So this is the area where they are most commonly found. Hence, a paramedian approach would be better for doing a thoracic epidural. Caution has to be exercised in anticoagulated patients for both lumbar and thoracic epidural, and use of modalities like ultrasound, fluoroscopy should be advocated and should be used freely to increase the precision. Similarly, in case of lumbar epidural, whenever the epidural anesthesia is contraindicated, please go for peripheral nerve blocks and facial plane blocks for all the lower limbs and abdominal procedures. And caution, of course, has to be employed in anticoagulated patients. Thank you very much.